Welcome to the DX Today Expert Report. Today, we're diving into the absolute cutting edge of clinical transformation, looking specifically at the intersection of artificial intelligence and healthcare regulation. We just saw the 2026 Healthcare Information and Management Systems Global Health Conference wrap up in Las Vegas. The atmosphere there was completely unprecedented.
Unprecedented is the right word. We had about 25,000 attendees on the exhibition floor, and the conversation has fundamentally shifted. People are no longer just marveling at the theoretical promises of AI or looking at predictive dashboards. Health system leaders are completely focused on practical, secure, and highly regulated implementation inside real clinical environments. They want to know how to deploy autonomous intelligence right at the point of care.
That urgency is coming from a very real place. We are looking at workforce shortages projecting massive multi-specialty deficits all the way through 2038. Health systems are under incredible pressure to deliver care more efficiently. Because of that pressure, clinicians are essentially taking matters into their own hands. Recent surveys show that 58% of frontline health system staff have used generic, free shadow AI tools for work at least once a month.
That 58% figure is alarming. It exposes a massive failure in institutional governance. Frontline workers are just trying to reduce their cognitive burden, but using unsanctioned shadow AI introduces massive risks. That was the big takeaway at HIMSS 2026. The technology is advancing at lightning speed, and our regulatory frameworks are buckling under the pressure. We have officially entered the era of agentic AI in healthcare.
To really understand how disruptive agentic AI is, we need to look at how artificial intelligence was traditionally regulated. For decades, the FDA evaluated AI using its software as a medical device framework. They treated algorithms as static tools that needed pre-market review before they could be commercialized. Since 1995, the FDA has authorized more than 1,300 AI and machine learning-enabled medical devices under this legacy framework.
Most of those early approvals were heavily concentrated in radiology. They were built to assist human clinicians by flagging anomalies in imaging data. GE Healthcare really led that charge. They actually top the FDA's list right now with 115 AI-enabled medical device authorizations. More recently, we've seen this traditional AI expand into cardiology and neurology, but the key word here is traditional. The FDA's approach was built entirely around locked algorithms.
Right. If a developer wanted to improve their model based on new data, they had to notify the agency about their update plans and usually go through a whole new clearance process. The FDA tried to modernize this by offering guidance on predetermined change control plans, which let developers map out how a device might be updated once it hit the market. And that worked fine for single-purpose predictive AI.
A great example of that working well is the FDA's recent authorization of ADOC's AI triage system. It is a comprehensive platform that detects 14 different acute conditions from CT scans. It combines multiple indicators into a single workflow, so they didn't need separate approvals for every single condition. But that is still predictive AI. The entire regulatory scaffolding is falling apart now because the underlying technology has shifted from locked predictive models to generative foundation models.
That brings us back to agentic AI. We aren't just talking about a chatbot that answers a prompt anymore. Agentic AI refers to systems that can interpret a complex goal, break it down into sequential tasks, access external databases, interact with other software via APIs, and evaluate its own progress until the goal is met. It is autonomous reasoning and multi-step planning.
Exactly. At HIMSS, Epic Systems made a massive splash by announcing Agent Factory. It is a fully integrated platform that lets healthcare organizations create, customize, and monitor these AI agents across clinical and operational workflows. They also showed off their conversational AI assistant named Art. Art can interact with real-time patient data. A clinician can literally ask Art how a patient's blood pressure is trending, and the AI will pull the data and automatically draft hospital course notes. That one feature alone is reducing discharge summary times by 20 to 30%.
But deploying a software entity that thinks, acts, and evolves creates severe regulatory hurdles. During the conference, Jared C. Hafer, a senior advisor in the FDA Commissioner's Office, pointed out that autonomous AI requires constant notification about update plans. Agentic AI models experience drift. Their performance can degrade over time as they process new demographic data or adapt to shifting clinical guidelines. They need continuous real-time oversight, not a one-time pre-market review.
What is truly fascinating is that the FDA is not just struggling to regulate agentic AI, they are actively deploying it internally. In December 2025, the FDA announced they were using agentic AI to help agency employees with meeting management, review validation, post-market surveillance, and even pre-market reviews. They built this off the success of an internal large language model tool named ELSA, which was voluntarily adopted by over 70.
While the technology races forward, the legal environment governing its use has become chaotic. We are currently watching a fierce jurisdictional tug-of-war between the federal government and state legislatures. On the federal side, the Trump administration has been highly deregulatory. They want to remove barriers to entry, prioritizing American innovation and speed to market over preemptive guardrails.
That push really accelerated in December 2025 when President Trump signed Executive Order 14365, titled Removing Barriers to American Leadership in Artificial Intelligence. This mandate actively discourages states from enforcing AI regulations that conflict with federal policy. It calls state laws onerous and a threat to interstate commerce.
The financial leverage being used is massive. The administration authorized withholding $21 billion in broadband equity and access deployment funding from states that refuse to repeal restrictive AI statutes, and this is being backed up in Congress. Senator Marsha Blackburn introduced the Trump America AI Act in January 2026 to codify the executive order and create a unified federal AI governance framework that explicitly preempts conflicting state laws. Concurrently, the Department of Health and Human Services announced a One HHS AI strategy to integrate machine learning across federal health agencies to accelerate medical product pipelines.
But the states are not backing down. Because they feel there is a lack of stringent federal guardrails, state governments introduced over 100 AI-related measures in the 2025 legislative session alone. Colorado has really emerged as the epicenter of this pushback. They passed the nation's first AI anti-discrimination law, which took effect in 2026, and they have followed it up with very specific healthcare bills.
House Bill 1195 in Colorado is a perfect example. It explicitly prohibits psychologists and social workers from using AI chatbots to communicate directly with clients or presenting chatbots as licensed human clinicians. Then you have House Bill 1139, which bans health insurance companies from using AI systems exclusively to deny coverage. Insurers must have an individual's medical history reviewed by a qualified human expert.
This creates a convoluted nightmare for providers and payers operating across state lines. You have the federal government aggressively dismantling barriers, while individual states are erecting targeted, use case-specific walls. Enterprise healthcare IT leaders are dealing with severe regulatory whiplash.
To understand how these forces are colliding in real time, let's look at a few defining case studies unfolding right now. The first one highlights how far the federal government is pushing the boundaries. The Advanced Research Projects Agency for Health, or ARPA-H, launched the Advocate program in early 2026. Advocate stands for Agentic AI-Enabled Cardiovascular Care Transformation.
The ambition of the Advocate program is staggering. The goal is to develop the first FDA-authorized agentic AI technology capable of providing 24/7 specialty care for cardiovascular disease. We are talking about a patient-facing AI agent that will autonomously connect to electronic health records, integrate with patient wearables, schedule appointments, and literally adjust medications without immediate human intervention.
ARPA-H knows exactly how much regulatory friction this involves, so they are co-developing the project directly with the FDA on a highly compressed 39-month timeline. They are trying to set a permanent regulatory precedent for using autonomous generative AI in high-risk clinical settings.
Compare that ARPA-H program to our second case study, which is the legislative firewall going up in Colorado. While the federal government wants to automate cardiology, Colorado is legally mandating human intervention. House Bill 1195 makes it a crime to advertise generative AI tools as psychotherapy without a human clinician. And House Bill 1139 forces insurers to keep a qualified human expert in the loop for prior approvals and coverage denials.
If you are an enterprise IT leader deploying payer-side AI, those Colorado bills mean you have to immediately change your architecture to hard-code human-in-the-loop routing into your workflows.
That need for hard-coded governance brings us to our third case study, which actually comes from outside of healthcare. The governance gap we are seeing in hospitals today perfectly mirrors the crisis that regional banks in the banking, financial services, and insurance sector are currently wrestling with. BFSI regional banks entered 2026 facing a mandate for continuous compliance regarding AI model risk.
The banking sector is a perfect blueprint for healthcare right now. Global pressures like the EU AI Act classify banking AI systems as high risk. Regulators are taking existing model risk management guidance and applying it directly to AI and machine learning. Banks have to provide complete model lineage, bias testing results, explainability standards, and clear thresholds for human override.
Healthcare is facing that exact same reckoning, but with literal life or death stakes. The Department of Health and Human Services 2024 Section 1557 final rule reframed AI in healthcare as a civil rights issue. If a healthcare provider receives federal funding, they have to ensure their AI clinical decision support tools do not result in discrimination based on race, color, national origin, sex, age, or disability.
Just like a regional bank has to prove its lending algorithm doesn't violate fair lending laws, a hospital has to prove its AI triage tool doesn't deprioritize protected patient classes. Institutions like the Chiba Bank Group in the APAC region and stateside regional banks have stopped treating AI governance as a yearly audit. They have established dedicated AI governance committees. They have appointed chief AI officers who report directly to the board.
Those banks utilize rigorous controls to regulation mapping. They evaluate AI systems for explainability, fairness, and transparency before those systems ever touch live customer data. They treat governance as muscle memory, building audit-ready evidence packs to prove their algorithms do not hallucinate or discriminate. Healthcare organizations must adopt this RegTech methodology to manage the risks of agentic clinical AI.
Looking ahead to late 2026 and 2027, this supremacy battle between federal deregulation and state-level guardrails is inevitably heading to the courts. The DOJ's AI litigation task force is going to clash with states like Colorado and California. They will be arguing the constitutionality of localized AI restrictions under the Commerce Clause.
While that plays out in court, the industry is increasingly leaning on private-public consortiums to self-regulate. We are seeing great work from the Coalition for Health AI. They have 1,300 member organizations, including Microsoft, Google, Amazon, and major health systems. They have launched model card registries, which essentially act as nutritional labels for algorithms. These registries allow hospitals to transparently evaluate validated AI products, assess their training data, and review their bias mitigation strategies before they buy anything.
We are also seeing a major shift in hardware toward medical edge computing. Companies like Advantech are demonstrating hardware platforms designed to run AI locally on bedside diagnostic equipment. Instead of relying on cloud latency and sending data back and forth, they are processing patient data in real time, embedding the AI directly into the physical clinical environment.
Navigating this landscape requires a very specific strategy. For enterprise leaders, the first step is to establish a comprehensive AI use case inventory. You have to eliminate shadow AI. Audit your networks, find out where unsanctioned generic large language models are being used by clinical staff, and build a living inventory of all AI systems influencing your decisions. You need to document their data sources and exactly how much autonomous authority they have.
Second, you need to implement that BFSI-grade model risk management we discussed. Adopt the frameworks used by regional banks. Institute independent validation of AI outputs, demand strict explainability, and set up continuous performance monitoring to catch algorithmic drift. Organizations should be securing URAC Healthcare AI accreditation or similar third-party validation to prove they are operating responsibly.
Third, hard-code human-in-the-loop escalation pathways into your systems. State laws like Colorado's HB 1139 and federal discrimination rules under Section 1557 make this non-negotiable. Agentic AI workflows must have clear thresholds for human override. The AI is augmented intelligence. The clinician must provide the ultimate ethical judgment and hold the accountability.
Finally, demand vendor transparency through those model cards. Most health systems are buying their AI, not building it from scratch. You have to force your software partners to provide standardized model cards detailing their training methodology, bias testing, and failure rates. If a vendor cannot explain exactly how their AI reached a conclusion, that software belongs nowhere near a patient.
HIMSS 2026 proved beyond a doubt that AI is the operational reality of modern healthcare. The leap from predictive algorithms to autonomous agentic AI has unlocked efficiencies that could save an industry struggling with massive workforce shortages. But technology without governance is an absolute liability.
We are caught in a standoff between aggressive federal innovation policies and cautious state barriers. Surviving this requires sophisticated risk management. By looking at how the banking sector handles model risk, healthcare organizations can chart a secure path forward.
The successful deployment of clinical AI isn't going to depend on how complex the algorithm is. It will depend entirely on the strength of the human governance surrounding it. The most valuable AI systems of the future will be the ones that are defensible, transparent, and ultimately empathetic to the human condition. Thank you for joining us on the DX Today Expert Report.